Welcome to the Common Sense Call-In. My name is Kristin Strohm, and I'm President and CEO of Common Sense Policy Roundtable. At Common Sense Policy Roundtable, or CSPR as we like to call it, we believe sound fiscal and economic research is essential to uphold Colorado's economic vitality, future, and individual opportunity. Our mission is to research and promote common sense solutions for economic issues facing Colorado. This call is an opportunity for those of you joining to learn more about the economic and policy issues that impact you and the future of our state. Today we'll be dissecting our recently published healthcare public option study, anticipating a state option for healthcare. Will businesses face higher costs, or will quality and access be cut? We conducted the study with the REMI Partnership, and I want to update listeners on who the REMI Partnership is. It was formed to provide Colorado lawmakers, policymakers, business leaders, and citizens with greater insight into economic impact of public policy decisions that face the state and surrounding regions. The parties involved include the Colorado Association of Realtors, the Colorado Bankers Association, Colorado Concern, and Denver South EDP. Before we begin, just a quick reminder to save the date for our healthcare forum that we are co-sponsoring with the Denver Business Journal on October 3rd at the Denver Museum of Nature and Science. If you'd like more information or to attend, please RSVP on our website. You can also download a full-length version of our study at our website, www.commonsensepolicyroundtable.org. Joining me today is Chris Brown, CSPR Director of Policy and Research. Chris, thanks for joining us.
Thank you for having me today.
So let's just dive right into it. Can you give us an overview of healthcare in Colorado today? What's the current landscape? How has it changed over the last decade? How are people getting their health insurance, and who's picking up the tab?
Yeah, absolutely. So I think where you would start in the healthcare discussion is there has been significant recent changes to the healthcare system over the last several years that have impacted the system in a couple different ways. No one has escaped the overall rising of costs and out-of-pocket expenses related to our healthcare. But I think there's a couple important dynamics to understand just from a basic level. Because of the Affordable Care Act, following the Affordable Care Act and the expansion of Medicaid here in Colorado, the uninsured rate has dropped to just below 7%, while the largest segment of coverage remains the employer market. It has actually seen a net decrease in those enrolled in the employer market and in the individual market, which represents the private sector market for healthcare coverage. At the same time, we've seen a net increase in coverage from public sector related to Medicaid and Medicare. And so this dynamic has caused a large shift and a significant disruption, and that's playing out as it relates to costs and overall prices.
How does Colorado rank nationally in terms of healthcare? I know that there's been a lot of different reports, and is Colorado doing okay overall as a state, or where do we rank?
Overall, Colorado certainly gets a clean bill of health in many ways, and Coloradans rank very high as it relates to health levels generally at a population level, and the quality of care ranks relatively high. But as some of these national studies pointed out, as I talked about in the opening question, Colorado still has problems as it relates to overall costs and prices, particularly as it varies across the state and different parts of the state, particularly in rural or some of the mountain communities.
So those costs have obviously become a hot topic in Colorado. In this past legislative session, the governor's office and the legislature talked about their plans to bring down the cost and help with access as well and affordability. So one of the bills passed during the session was House Bill 1004, which would create a state option health care plan. Can you walk us through what that bill is, what it does?
Sure. I think what what people on the line should be aware of is that this bill, House Bill 1004, created or mandated the Division of Insurance and the State Healthcare Agency, HCPUF, to develop what is called a proposal for a state option. It's unclear exactly what the design of this will be just yet, but those two agencies have held stakeholder meetings through the summer. They are currently sort of behind closed doors developing that proposal and are set to unveil it later this month, in the next 2 weeks, at the end of this month, in fact. And so we'll have a much better idea exactly what this proposal will look like, but effectively it is either a publicly run plan or a more heavily regulated, publicly managed plan operated by private insurers that would compete in the private market against current private insurers. So it's a little unclear exactly what the design will be, but the intent is to create a new type of insurance, either offered by the government or contracted through the government to compete in the existing marketplace.
Has this ever been done anywhere else in the U.S. before? What do we know about, implementing something like this and if it would work?
This has never been fully implemented. It's been discussed and debated for over a decade now, or longer even. Yet Washington State, just this year, during their legislative session, had a debate on a state option and actually passed legislation to implement a state option, and over the next 2 years, they will begin enrolling people in a state option plan. They will be the first, potentially be the first in the country, depending on when Colorado begins their implementation. But so to your question, we do not have any real experience. We only have what health actuaries and what health economists have been saying about the Washington State plan to this point.
So did they, obviously then they did some actuarial modeling on this Cascade Care out of Washington. What did you take from that, or what did you notice as you were looking at how that might impact the Colorado House Bill 1004?
Yeah, so as we often do with the studies, as we always do when we embark on a new study, we try to look for literature that's out there, look for research that's out there, try to get a sense of what other experts are saying on the subject matter. We were able to track down an actuarial analysis on an early version of Cascade Care, or of the Washington State public option. And in reading through that analysis, it really highlighted some interesting features, some really compelling features and unintended consequences, and what the dynamics of a state option could mean for a state healthcare system, for a state insurance marketplace, and for the broader economy. So there was again, this analysis that we were able to get our hands on was done by a global consulting firm that has health actuary expertise. The group is called Milliman. They released this study through one of the associations in Washington State, and we were able to use that as really the basis for our work to try to help explain these dynamics to Colorado voters, so when this proposal is ultimately unveiled, as a state, as a elected voter base, as elected officials, be more informed as to what those potential dynamics could be, as there's only about a 2-week period between when this proposal will be released and when the public comment period will conclude before the final draft of this proposal is unveiled and sent to the legislature come mid-November. So during that 2-week time period, we really wanted Coloradans, again, to be tuned in to what is unveiled and be able to ask more informed questions because of the extent to which this could impact their lives.
So that's, this study that you released is fairly complex, has a lot of parts to it. Let's kind of delve into it with the listeners, and so that they can have a better understanding about the key findings, but also the assumptions that the study was premised upon. So can you walk us through some of the bullet point assumptions that were made when you were working on this study, and then perhaps some of the key findings as well?
Yeah, absolutely. So going back to the first question, I think it's important to understand how people are currently covered. Again, a little less than 50% of Coloradans are covered by employers. About 8% of the state is covered on the individual market. They purchase insurance as an individual, either through the health exchange or off the exchange, but as an individual. Then you have the public payers. You have Medicaid and Medicare, and you have a portion that is uninsured. You also have CHIP Plus, which is another public payer. So you have the public market and you have the private market. And so what this Milliman study articulated was the extent to which a new state option would effectively draw people as people looked at a state option that potentially was significantly cheaper, and we'll get into the reasons why a state option could be significantly cheaper than the current alternatives on the individual market. And people looking at these trade-offs would look at the state option, see a lower price point, and opt to purchase the state option and buy into the state option as opposed to remaining in the individual market. Or employers would perceive the state option to be less expensive and move their workers into the public option as opposed to covering them through employer coverage.
So what were the two, I know there were two scenarios that you ran. What were the differences in those two scenarios and the assumption? I know that it was a price reduction.
That's right.
In the two scenarios. So what was the difference in those two, and what was it? Where did you kind of come up with that assumption?
Yeah. So the Milliman study and this early version of Cascade Care, the sort of linchpin to this whole discussion is the extent is what the insurance pays medical providers, what insurance pays for the procedures that people that they're covering are receiving, and that's called the medical reimbursement. And in this version of Cascade Care that Milliman studied, it was proposed to have reimbursements set at 100% of Medicare rates. And Medicare and Medicaid currently in Colorado, according to state reports, pay 69 cents for every dollar of expense. And so when you have a public option that now pays significantly less than the expense of care and significantly lower than the private option, you would see providers facing a trade-off. To your question about two scenarios, effectively, the Milliman study articulated a range of potential impacts from setting a public option reimbursement rates equivalent to Medicare. So that would either translate to a relative price reduction of either 24% or 42% relative to the existing coverage that you could purchase in the individual market. And so the two scenarios we outlined were based upon those two price reductions for consumers that would then translate to different levels of adoption or migration from existing coverage to the state option.
So the state option, essentially, it will be cheaper for people to get on, but well below what the cost of care is. So somebody has to pick up that cost. Is that the concluding point, that it's this cost shift? Either the healthcare industry will have to pick it up or the private market?
Yeah, so we wanted, I think that's spot on. We wanted to articulate that trade-off, and we found that under those two scenarios, at a 24% reduction in price, the net medical revenue loss to healthcare providers was roughly $500 million.
On the low end?
On the low end. that grew to about 1.4, nearly $1.5 billion across the state if prices were reduced by 42%, again, maybe as a high bookend. And so that $500 million to $1.4 billion represented a loss, a net loss in medical revenue without addressing the actual cost of delivering care or providing care to these individuals. And so that's where providers would then face these fundamental trade-offs as to how do you compensate for those losses in revenue. Do you, and we articulated sort of two broad pathways, and to give, again, readers a sense of the scale and the magnitude on both sides, but would you, as a provider, either eat those costs effectively, and that translates to less money available for labor, less money available for investing in new technology, new equipment, or would you try, to the extent you could, make up those costs, those lost revenue, by passing those on through the form of higher costs to the remaining private insurance market, which at that point would be primarily employers. So we present this trade-off, which would be either reduce expenditure in the healthcare market, which would translate to roughly a reduction in roughly 4,500 healthcare-related occupations, or shift costs to employers, representing at the minimum maybe a 5-6% increase in employer costs related to providing health care, which would then translate to higher costs of business, which would translate to roughly 8,300 fewer jobs throughout the state as a result of, again, shifting and passing costs on to the remaining private insurance market or employers. And so these trade-offs are what providers would face, and what the sort of unintended consequences of establishing an underpriced new insurance product would mean for the market and for the broader economy.
So you say unintended consequence, and I want to just kind of delve into one key point you mentioned earlier a little bit more. Colorado right now has disparity across the state in terms of healthcare access, and I've read that there's recent findings that there are a lot of different areas in Colorado that are already underserved markets. So what do you anticipate this would do to those already underserved population areas? This is, I think the governors and the legislature was well intended in trying to come up with something that would actually help those individuals or help them gain more access. What do you think that this would ultimately do to those areas?
I think you make a great point. The challenge is that a lot of the markets where prices are higher are in, let's say, more rural communities, and there's a lot of reasons why the dynamic is different in rural versus more urban markets. But to the extent you set a reimbursement rate well below the existing private market, you would see larger or disproportionate negative effects in areas with relatively higher prices. What that means is that these rural markets that already face shortages as it relates to professionals, or as you put it, are designated as medically underserved regions and may also have relatively higher prices, you would see significantly larger losses as it related to medical revenue, and potentially having disproportionate impacts on the economy, given a large part of rural economies are often supported by healthcare professionals, hospitals are sometimes the largest employer, and so there would be a disproportionate effect potentially in some of these markets. And so in attracting more people to a lower priced plan, you actually further remove the revenue from the providers that were remaining in these regions, and even exacerbate the issue of access and availability of practitioners willing to work in these communities.
Chris, any final thoughts before we wrap up this really interesting topic? And again, for those of you listening, you can find more information or the full report on our website, commonsenspolicyroundtable.org.
Yeah, I just hope that people are tuned in to this release of the proposal, are interested in asking questions, or tuned in to sort of how this might impact them, whether you live in the Front Range, you live out in Grand Junction. The impacts could be significant, and we want people to be tuned in. And to the extent policy moving forward can address costs as opposed to just prices, I think we would not see these unintended consequences, these potential negative effects. A difficult challenge, certainly, but I think it's sort of the goal that we're all working towards.
Great. Thank you for joining us today, Chris.
Thank you, Kristen.